are starting on the nursing process. However, before we get started, I put a couple videos up here that I thought were very interesting. And I would like you to watch these, take a little bit of time, watch these two videos, and then try to answer these questions and think about these questions for a minute before we start to go into nursing process. And hopefully we'll talk a little bit about this at the beginning of class next week on Wednesday, but hopefully you'll be able to take away something from these videos so that you can take care of your patients a little bit better or have a little bit different understanding of patients with cognitive disorders. So the first thing we're going to talk about in the nursing process is assessment. And in your lecture outline, you have a table there. I did not put the table up here, so you can just refer to your table that's in your outline. But when we're doing an assessment, we need to make sure that we, especially with people with cognitive disorders, that they are in a comfortable environment and that they are free from distraction. This is going to be very important because, again, if they're having difficulty thinking, processing, taking in information, assessment may be somewhat difficult. So we want the environment to be best suited to them as possible. We want to make sure that we also pace our questions so that there's plenty of time for them to answer, take in information, process the information. So we need to collect subjective data first. And one of the ways we can do that is through a health history. And it's very important that we get their present and past medical conditions and any recent changes that they've had. Again, this is going to be very important as we are trying to determine, is this delirium that's going on or is this a dementia that's going on? Sensory impairment is also important, especially hearing and seeing. If those two senses are impaired, that can play a significant role in the person's ability to process information and take in stimuli. So it's very important that we assess that as well. Dietary history, how much food intake are they actually having? Okay, what are they taking in? And we can try to ascertain by asking either the client or family members. We know that if they don't have enough food intake, or if they are lacking a certain vitamin, that can also cause problems with cognition. I have down there the vitamin B12 deficiency is one really good example of that. Dehydration can also cause cognitive impairment, and so we need to be very aware of that. Head trauma history is important. Medication, both prescription and over-the-counter, we need to make sure that we're asking about that, and over-the-counter as well as if they're taking any herbal supplements, that sort of thing. We know that with elderly that they are much more prone to drug reactions, so it's even more important that we try to get what the medications that they're on, but also have they stopped a medication recently? Have they started a medication recently? Alcohol consumption, again, very important. We know that alcohol can cause dehydration, which again can cause cognitive impairment. Alcohol is a CNS depressant, which can, again, by itself cause problems with cognition. If a person is intoxicated, many times that can mimic dementia, but that also is delirium. And alcohol consumption also impairs a person's nutritional status. Many times if a person is taking in alcohol, they are using those calories instead of getting nutritious calories and vitamins and minerals that they need from a regular diet. And a person who is taking in alcohol can impair the absorption of nutrients in the stomach. It can block out absorption in the stomach, so we need to be aware of how much they are drinking. The next column, psychosocial assessment. Family history is very important. We talked about family history being a risk factor, so that is important. It's also important to use other family members to help get a good source of information. They may be able to give us a lot more information than the client is able to. We also want to do a family assessment. How is the client and the family interacting with each other? What is their family dynamics? What is the housing situation? Who's taking care of the client? That sort of thing. ADL and a functional assessment, very important so that we know where they are. It will help us determine possibly a stage of dementia or a stage of Alzheimer's that they might be in. But are they able to do ADLs? Where are they in that process? Community functioning, how are they sustaining themselves in the community? Are they able to participate in community activities? Again, very important in trying to determine what resources they may need. Objective data, physical assessment, very important. We need to have a very thorough medical workup, and we need to complete a neuro as well as a psychiatric assessment and workup. This is going to be very important so that we can, first of all, rule out any other medical problem or any underlying systemic illness that needs to be taken care of. So that is very, very important. And sometimes physicians and the healthcare team needs a nurse to advocate for that patient and advocate to get a thorough workup. The lab, I want you on page 281, there is a, in the second column, there's a area that talks about the labs that are ordered on all elderly, and I want you to know all those labs and the reasons for those labs. So that's page 281, and I want you to know those labs. Imaging techniques, depending on the client and their past history, chief complaint and that sort of thing, we may do imaging techniques. That should say techniques, not technician. So it might be MRI, CAT scans, CT, that sort of thing. We also may do some EEGs. So there may be a variety of things that are also ordered. Cognitive function, very important that we're doing a mental status exam. And again, you guys know all how to do a mental status exam now. You know what a mini mental status exam is. So, but we want to be looking at the appearance, manner, attitude, but also all those cognitive functions. Of course, we're looking at behavioral changes as well. How have there been changes in behavior? Okay. That moves us into the next slide, which is the nursing diagnosis. And as we're talking about nursing diagnoses, I want you to know the nursing diagnoses that go with the delirium and dementia, but I also want you to know the etiology, or why, and I want you to ask your question. Why might a person with delirium or dementia have a risk for injury? And then if you can list those reasons why they might have that nursing diagnosis, then you should feel like you're well prepared. And that's what we're going to go through right now. So if we start with the first one, and risk for injury and impaired physical mobility go together and kind of support each other. But risk for injury, why would a person, again, like I said, with delirium or dementia, why would they be at risk for injury? You should be able to come up with a variety of things based on what we talked about on our first lecture. So it may be that they have that spatial disorientation. It may be that they have sensory impairment, poor eyesight, poor hearing, that can make them at risk for injury. It may be that they are not able to process information, understand what's going around in their environment. Okay, so that's what I want you to do. Why would these people be at risk for injury? They may also be at risk for injury because they have a impaired physical mobility. Again, why might this person have an impaired physical mobility? Many times elderly people have gait changes, and if there's neuro involvement, they might have even more gait change if they have neurological damage. As I mentioned before, that spatial disorientation, people with impaired physical mobility are more prone to falls. So I want you to read about those and take notes on those from your book. Slide gives us some more nursing diagnoses. Why is it a person with delirium or dementia, why are they have a diagnosis of self-care deficit? Well, with delirium, we know that it's very difficult for them to organize the information in their head and also to carry out those tasks or that information that is in their head. Okay, again, so not being able to carry out ADLs. And many times with both delirium and dementia, they may be a person that they need total care needed in their ADLs, depending on what stage they are in dementia, or it may be just they need a small assistance with that. Sleep pattern disturbance. and also readiness for enhanced sleep. Those two kind of go together. But again, what are some things going on that would give a person with delirium dementia this nursing diagnosis? Well, first of all, we talked about sundowning, that many times as the evening sets in, the person becomes more confused because, as I mentioned before, the sensory stimulation is very low, and so they start to become confused and start having have difficulty going to their room, laying down, and falling asleep. Instead, they may become very restless, not want to stay in their room, start wanting to come out of the room, that sort of thing. Readiness for enhanced sleep, that would be when we are aware that they need to be ready for sleep, but also if they are asking for assistance as well. Okay, disturbed thought process. Those would be some of the things that we've talked about. I gave you, such as agnosia, memory problems, if they're disoriented or oriented only times one, if they're having delusions. These would all fall under that disturbed thought process. Impaired verbal communication. Again, if a person has aphasia, whether it's receptive or expressive, and even in the late stages of dementia or Alzheimer's, many times they are actually mute and don't speak at all. So that's obviously going to impact verbal communication. If the person is doing a lot of confabulating, that also may impair verbal communication. Okay, the next slide, we talk about risk for violence, which might be self-directed or directed at others. Why would a person with delirium or dementia have risk for violence? Well, many times we know that people with delirium and dementia are disinhibited, and they have, meaning that many of their impulse control is decreased, and so they aren't able to inhibit maybe the thought of wanting to hit somebody or doing some type of risky behavior. They also are more prone to do decreased socially acceptable behavior. So again, they might start cussing at somebody. That might put them at a risk for violence. Somebody might hurt them. You know, if they're in the, say, an inpatient unit and they are acting out by, cussing or calling people names or striking people, that might put them at danger for people getting angry at them and causing violence towards them. Risk for violence, also some, like I said, unpredictable behavior, and also impulsive behavior. Ineffective role performance. This would be if they have a decrease in functioning in their ADLs, of course. If they have any kind of regressed behavior that produces a lot of anxiety or grief. And just some of the facts in the beginning of Alzheimer's disease, when they start to find out or start to see that they may not be able to keep their job. Maybe they aren't able to function as a supporting the family or being a role model for people or taking care of their spouse or family responsibilities. Sensory and perceptual alterations. These would be individuals who have hallucinations and illusions. They have difficulty telling what is reality and what isn't in reality. We've mentioned, as we looked at the stages of Alzheimer's, looked at some of when hallucinations might become more prominent. We also know that anybody who's going through delirium very likely could be experiencing hallucinations. One common one with alcohol withdrawal is feeling of bugs crawling on your skin. Okay, so that's a common hallucination, but that falls under sensory and perceptual alterations. Risk for situational self-esteem. We talked about this a little bit before in that first stage of dementia, where as the patient starts to forget things, starts to become a little bit confused, many times they are actually aware of this decrease in functioning, which can cause low self-esteem, decreased confidence in themselves, anxiety. Alteration and elimination. We haven't really talked about this, but urinary or bowel incontinence. In the later stages of dementia, Alzheimer's disease, many times we'll have this issue with alteration and elimination, mostly due to confusion. A person not it's not necessarily that their physical functioning has changed. It's just that the confusion, sometimes they're not able to interpret what that bodily sensation is. That means I need to have a bowel movement, or I need to go to the restroom, that sort of thing. So many times they are incontinent, and it's difficult for them to control. It's even difficult for them to tell somebody else that I need help going to the restroom, I need help with this. Alteration, one thing I don't have on the slide, but that it is on your outline, is alteration in nutrition, imbalanced nutrition, less than body requirements. We already talked about this in the assessment, how important it is to do a assessment of their nutrition, but many times these people have poor nutrition, again, due to confusion, due to forgetting to eat, not understanding or not being able to interpret sensations in their body of hunger. And then the last one, we often see this with delirium and dementia, acute chronic confusional state, and that is just when they are, what is that related to, but the it might be because of excess intake of alcohol, or it might be related to a head injury or something along those lines. So, outcomes. I have on your lecture outline, I have the main things we need to be concerned about here. First of all, with dementia, the outcome here is that we want to maintain optimal cognitive function, and then also to support the family. We're not going to get them back to their normal functioning level, okay, or their high level of functioning before they started having dementia, but whatever functioning they do have, we want to maintain that at the highest level possible. We also want to support the family and all their endeavors to support their family member, but help them through, whether it be education, whether it be respite care, any way that we can help support the family. Delirium, the outcome here is that we want them to return to their previous level of functioning. And on page 251 in your book, oh, I'm sorry, scratch that. So we want them to return to the previous level of functioning, and it should be back at their normal level, high functioning. Planning, implementation, and interventions. Okay, I'm going to be going through this, but what I want you to do is to read the interventions that are in their boxes. They're going to be giving a lot of examples. So throughout your book, you are going to be seeing various boxes that talk about communication, but that also talk about various interventions, and I want you to make sure that you read all of those. I'm not going to go, give you lots of lists and that sort of thing in addition to this lecture outline, but it'll be your responsibility to make sure that you read those and to know those. Okay, so let's start with this planning goal with dementia. Two goals that we want to maintain with dementia is maintain the patient's safety. This is obviously always going to be the first priority. So if you ever have an NCLEX question that asks, what is your highest priority for this patient, it's going to relate around safety. And then we also want to minimize self-care loss. And that goes back to that outcome. We want to maintain their optimal cognitive functioning and their optimal functioning. Goals with delirium, we want to support the existing sensory perception until their cognition clears. So we want to, whatever their sensory perception is, whatever they are able to do, whatever they're able to process, we want to support that and encourage that until the cognition clears and they're back at their normal level of functioning. Okay. Okay, continuing with interventions, we want to make sure that we prevent and minimize injury. Again, that is always one of our top priorities, and whatever that would include, and we're going to be following along a lot with these. Promoting normal motor behavior goes along very well with minimizing injury. It's important to be aware of falls in this area of normal motor behavior, and you guys learned, I'm sure, all last semester about how do you prevent falls in the nursing home, how do you prevent falls in the patient's environment. Some of the things we want to be doing is assessing their visual abilities. We want to look at to see if they have any balance problems. We want to check postural hypotension to make sure that there's no issues there. And we have known through research that allowing a dementia patient to wander in the hallways when they are close to bedtime, or if they're having sundowners, is much safer than forcing them to stay in their bedroom or forcing them to stay in their bed with restraints or any kind of interventions like that. We also want to promote adequate sleep. And again, I think you guys have talked a lot about this last semester, but all those things that you would do to promote adequate sleep, especially with a person who has cognitive disorder, would be making sure that there is a well-lit room, or that at least a room with enough light on that they can see, make out what's where their closet is, what the chair is, those sorts of things. We also want to possibly provide some soft music or allow the TV to be on in the background. It might also be having a snack with a good source of protein before they get to bed, nighttime routines, soothing bath, those various things. We also want to promote verbal expression, making sure that we give very clear, direct, and simple instructions if we want them to do something or are directing them to do something. If we know, or if we see they have a decreased inability to communicate or a decreased in verbal expression, we need to be looking for their nonverbals. Okay, that's very important. And any other ways that they can promote, or any other ways that they are expressing themselves. Maintaining self-care is another intervention. We want to allow them to do as much as possible by themselves. The more they can do on their own, the less anxiety they're going to have. They may need reminding. We may have to give them one task and wait and be patient while they do that, or let them work on it, leave the room, and then come back, and then maybe give some reminders. This can be very frustrating for family members and sometimes and many times for staff, but you need to be self-aware how frustrated this is making you, and either decide you can't work with this patient, or to check yourself at the door and make sure that you are going in with a non-judgmental attitude and a calm and non-frustrating approach. Some other things. Okay, we also want to maintain attention span. That's going to may be difficult, but the things that we can do to help with that is to decrease environmental stimuli when we are talking with them, or when we are teaching or working with them. Again, we want to be very slow and simple directions when we're dealing with them. Be direct. We may need to manipulate their environment to help them with certain memories. It might be calendars in the room. It might be decorations that remind them of the time of year, that sort of thing. We also want to maintain self-esteem. Listening to the client is very important. Taking our time and listening. Letting them begin to talk about their feelings. Allowing them to express their feelings. They might have anger, they might have sadness, and not always trying to cheer them up, or not always trying to get them out of an angry mood, but many times that anger and sadness needs to be expressed and is going to be helpful to them to process those feelings and to understand those feelings. They have the same needs as everyone else, the same need to listen, have somebody understand them. Got way off. Support optimal. Oh, I guess I'm missing one. Your outline says promote optimal memory function. This is where we want to orient the client, but we don't want to argue with the client and make a huge deal out of this orientation. But direct them to areas of interest, things that they're familiar with, and that are pleasurable to them. Okay, so it might be if they were a big farmer or in their day, to talk about those things, and that can help with that memory function. Things that are pleasurable to them. It might be songs, it might be stories. Music therapy can be very helpful. On page 315 in your book, I believe, let me just double check that. No, on not page 315, I'm sorry, but there is an area in your book that talks about confabulation, and as I mentioned before, that's a defense mechanism, and we do not want to argue with any type of confabulations that are going on. Optimal perceptual function. This is, okay, the perceptions, all the different senses that a person has. We want to make sure that their room is, excuse me, their room is well lit, that if they have hearing aids or glasses, that those are on. We want to remove any types of distractions. Low music or low stimuli in the milieu can be helpful to them to take in stimuli to know where they're at and decreases confusion. Some touch is okay, but really minimal touch. If a person is having hallucinations, we want to take care of the emotional response first. So for example, if a person is hearing voices, or possibly if they're feeling, bugs on their skin or whatever, we want to let them know that that must be scary. That must be scary for you to have that feeling, or to hear those voices, or to see that, whatever it is. Take care of that emotional response, and then reassure them that they are in a safe place. I also want you to look at see box 12.2 and make sure that you're looking at that as well. Okay, optimal nutritional status. We want to make sure that they have a dietary consult, but they have a diet that's high in protein and carbohydrates. They may need to be on I&O and daily weights. If that has not been ordered yet, that doesn't mean that as the nurse that we're oblivious to it, but we may be the first one to notice that they aren't taking in very much and they need to be on I&O. Okay? And bring that to the doctor's attention. We may also be noting that they're not taking in very much nutrition, and they need to be on daily weights. Okay. These individuals also may need to have assistance with actual feeding if they have forgotten how to use utensils, if they have forgotten how to feed themselves. And so again, being able to assess that and then put those interventions in place. People with end-stage dementia or Alzheimer's may actually have a feeding tube or an NG tube, so we need to be aware of that also, and then all those interventions that go along with that. Support patterns of elimination. The best way that we can do this if a person is having difficulty with incontinence is to have a regular toileting schedule, especially if they can't let the nurse know when they have to go to the bathroom. So a regular toileting schedule, and usually in nursing homes and hospital, one that works the best is every 2 hours. Disposable pants, if they can't follow that schedule, is important. Supporting appropriate role performance and self-control. Again, I guess I didn't have that on this slide, but it's in your outline. Optimal role performance and self-control. We want to make sure that if possible, that the patient is kept at home or with the family as long as possible, whether it's in their own home, with their own spouse. And we want to support that home care as much as possible and support that self-control as much as possible. Don't do things for them if they can do things themselves. Support appropriate conduct and impulse control. We want to prevent sensory overload. Okay, so that's kind of we want to make sure they have enough stimuli, that's coming in, such as enough light that's coming in, enough sound, so they don't become confused, but we don't want them to have an overload of sensory information that's coming in. We want to make changes in their environment very slowly, not quickly, and try to inform them ahead of time. When we are approaching a person with cognitive disorders, we want to approach them in full view so that they know we are coming, that we're not just coming up behind them and talking to them, or coming up behind them and putting our hand on their shoulder. But in full view, we want to use the patient's name and really refrain from touching. Okay. As this slide says, and I've kind of mentioned this before, but I want to make sure you look at all the green boxes that are in the book that have to do with communication. Look at those scenarios, look at what the nurse's response is, and read the rationale. If you don't understand the rationale, bring that to class or bring that to me. But that should be something that you're all doing. Also, I want you to see the care plan on 291 on delirium. Read that through and then let me know if you have any questions. And as I already said this, but also see the box 12.2 in your book. Okay, now we're going to be continuing to look at interventions, but looking at medication management as an intervention. First of all, with delirium. I'm going to talk about this in some later slides, but for now, what we're doing for delirium is we're treating the underlying cause, whatever is involved with that. If it's a UTI and treating with an antibiotic, that's what we would do. If it's alcohol withdrawal, we would treat medically for alcohol withdrawal. So depending on what the underlying cause is, we would treat for that. But then we would also treat for specific behavior such as agitation, hallucinations, that sort of thing, and I'll go over that in a little bit. So let's go to our next slide. Okay, now we're on our next slide, medication management. We're going to be with dementia. It's important to know that medication management with dementia, we can slow cognitive impairment, but we cannot prevent it. So if your outline still says prevent in there, I want you to cross that out. Well, the best that we can do is slow cognitive impairment with medications. One group of medication or class of medications is the acetylcholinesterase inhibitors. And this, I'm asking you to go back to page 135, which is your chapter on pharmacology, and read about those medications for Alzheimer's disease. This is where, as I mentioned at the beginning of the semester, is where I start to borrow from the pharmacology chapter and some of the nursing interventions for medications chapter. Okay? So that's back to at page 131 or 135. I have an example in your outline of 3 different medications that would fall into these cholinesterase inhibitors. In order to understand how these cholinesterase inhibitors work, we have to realize that acetylcholine is a neurotransmitter that deals with memory and processing information. Okay, but with Alzheimer's disease, there's a deficit in this neurotransmitter. There's some deficit in serotonin as well. If there's a breakdown of acetylcholine, and if that breakdown of acetylcholine is slowed down, that is going to promote or allow acetylcholine to build up, and it's going to promote acetylcholine, basically promote that its job, which is transmitting information from cell to cell, which is going to help with memory and it's going to help in learning. So acetylcholinesterase actually is an enzyme, and it breaks down acetylcholine. Okay, if we stop that enzyme, if we stop acetylcholinesterase, that will inhibit that breakdown process, and like I said, allow more acetylcholine to collect in the brain, and then allow acetylcholine to do its job, transferring that information from cell to cell and aid in memory and in learning. The medications that I mentioned above, or that were in your outline, there are a few nursing implications that I want you to know about. First of all, these medications can cause liver toxicity after being on them for a long period of time. Therefore, as nurses, we need to monitor liver function tests and enzymes. And they also have a few side effects, such as some of the GI side effects, nausea, vomiting, and also can cause headaches as a side effect. Moving on down on your outline, acetylcholinesterase inhibitors are effective in mild to moderate cases. Okay. If there is more acetylcholine in the central nervous system, that's going to help with the cognition and the memory, and therefore it may slow the progression. It's not going to prevent it or it's not going to stop it, but just slow it down. And the quicker we can diagnose this in the mild to moderate or into the mild moderate cases, or recognize it earlier in the stages of Alzheimer's, then we'll better able to treat it. But it's very difficult to start treatment at those early stages. If you recall, looking at those 3 different stages of Alzheimer's. Why is that? Why is it hard to start that treatment at the early stages? Well, one is that the person may not be aware that they are in an early stage. If they aren't aware they're in an early stage of Alzheimer's or dementia, they may not be going to the doctor. They may not be seeking help. Okay, and the only time that they may actually start to go to the doctor is when they're in the 2nd stage, or possibly even further. So that is one hindrance. And that is also could be the family member. The family member may not even recognize that their person or the significant other is in an early stage, and therefore don't think about bringing them to the doctor. They may just think that they're seeing signs and symptoms of aging. Confabulation is another reason. If a person is using a lot of confabulation, family members again might not recognize that they are in an early stage of dementia and may not be able to get them to the doctor, therefore may not be able to start that medication in an earlier moderate case. Denial is also a difficult a situation that may make it difficult to start treatment early. Denial of the patient, first of all, they again may be having some of those forgetfulness, can't find their words, that sort of thing. And again, it's just old age. I'm fine. This can't be Alzheimer's. This is everybody's going through the same thing. Now that's the patient, but loved ones can be in the same kind of denial. Oh, that's Dad. That's just the way he is. He just forgets things. We just help him out, and they are in denial that this is setting in, or denial of how significant the symptoms are, or if the symptoms are worsening. Another class of medications are the NMDAs antagonists. One example is Namida that I have down there. And this medication targets glutamate. Glutamate is a neurotransmitter, and normal levels of glutamate play a very important role in the neural pathway associated with learning and memory. So we need to have normal levels of glutamate. If we have abnormal glutamate activity, it can cause symptomatic cognitive deficits and neural toxicity, and that both of those have been thought to be involved in the destruction of brain cells associated with this Alzheimer's disease. Now, NMDA antagonists inhibit that abnormal glutamate activity, which again is going to slow down that cognitive and that functional deterioration that is apparent in Alzheimer's disease. So we're wanting to slow that down, and the antagonist helps to bring it back to a normal glutamate activity. Okay. The next slide talks about medication management in both delirium and dementia when we want to treat specific behavior of those disorders. So for example, both delirium and dementia, we can have patients who are slightly agitated or very agitated, which is making it difficult possibly for them to sleep, or difficult for them to cooperate with treatments. So there are some medications that we can give for that specific behavior. We can give atypical antipsychotics. I want you to cross off Haldol if I have Haldol there on your outline. And I do have Risperidol. Risperidol is an atypical antipsychotic, but we want to give in a very small dose, 0.5 to 1 milligram. And remember, in elderly, we always want to remember about starting low and going very slow as we increase. If a patient has a specific behavior of depression or anxiety, we can give an antidepressant that will help with that depression, and along with it, it may help with anxiety. We can also choose an antidepressant that has anti-anxiety properties that would also help with the anxiety. If sleep seems to be a problem, and we're using all the nursing non-pharmacological nursing interventions for sleep, we may want to get an order for a low dose, again, of an atypical antipsychotic such as risperidol, and a very, like I said, very low dose that may help with sleep. If our patient is having hallucinations, delusions, again, a low dose of atypical antipsychotic can either remove those hallucinations and delusions, or at least decrease them and keep them very minimal. With elderly people, we want to avoid sedatives, especially the benzodiazepines. These benzodiazepines can very much slow them down, may cause additional confusion, and may cause disorientation and that sort of thing. So we want to avoid benzodiazepine. Another reason why we want to avoid benzodiazepines is that in the elderly, it can cause a disinhibition, which again can cause the patient to do things that they wouldn't normally do, such as patient hitting out, striking other people, being uncooperative, that sort of thing. So we need to be real careful with about benzodiazepines, and then advocate for our clients with the physicians as well. All right, I don't know how community-based care, and that basically is talking about trying to keep the person in the community as long as possible. They may have appointments in the clinic, and that is good. A lot of times there are resources to help family members take their patients or family members to outpatient clinics, outpatient appointments. There are many different types of day programs available for elderly, especially elderly with cognitive issues. It's almost kind of like a daycare for elderly people, where a family member possibly could drop them off in the morning and then pick them up in the afternoon. But sometimes having extra attention during that time and extra therapies during that time can be helpful. Support groups for the patient, especially if they're in the early stages of Alzheimer's, can be very helpful when they are just starting to be aware that they have possibly been diagnosed or having these problems. The support can be very helpful. If a person needs counseling who has been diagnosed, this can be helpful in decreasing social isolation. Some therapy or counseling can help a person if they're dealing with loss, especially if they're in the beginning stages. But listening to the client, supporting their healthy coping mechanisms, giving them an outlet to talk about things can be very helpful. Home care, we mentioned that a little bit. Trying to keep the client in home care as much as possible. First of all, assessing the home. Is it meeting the changing needs of the client? Is it safe for wandering? Is it safe for a person who's forgetful? So a home assessment is going to be very important. We want to make sure that there's a balance of stimulation with rest for the client. Not too much stimulation, but not no stimulation at all, and make sure there's activity, but there's also time for rest periods. Hopefully we are able to look at families that are at risk for health problems, secondary distress, and provide support for them, respite care, counseling for the family members. How do I deal with my grief now that my father has Alzheimer's disease? That might be very difficult and might get in the way of me handling stress or get in the way of me taking care of my father. Okay, you can go ahead and read about case management and other aspects of home care in your book. I'm not going to go over those. I'm going to let you do that on your own. I would also like you to look at forget that. I've scratched that out. I'm going to go to and look at evaluation. Basically, when we're looking at evaluation, what are we doing in the nursing process? We are going back to the outcomes, and we're looking to see if the outcomes have been met. Okay? So with delirium, if you remember what that evaluation criteria was, are they maintaining optimal levels of sensory perception, and are we keeping them safe? Okay, so that's what we're evaluating with delirium. And then eventually, are they getting back to their normal level of cognition and functioning? With dementia, the evaluation criteria here is, are they at their optimal cognitive functioning? Are they at their optimal ADL functioning? Are we minimizing, self-care loss? Are we keeping them in a safe environment also? Okay, and that is the end of our lecture, and I'll see you guys on Wednesday, and we'll start talking about our next chapter, which is substance abuse.